Good morning, everyone. My name is Eric Borwinkle, and I have the pleasure of being the Dean of the UT Health School of Public Health. Thank you for joining us virtually for the first annual Texas Public Health Summit, both virtually and in person, actually. The purpose of this summit is to create a forum for a deep discussion on a single topic of pressing need and relevance to contemporary public health. It is our plan that the topic will likely be different each year. This year, the topic is public health communication. One of the major lasting lessons from the COVID-19 pandemic is the need for regular, clear, and factual communications. It is not a lesson that is limited to epidemics or pandemics, and it is a topic that, frankly, we should have paid attention to years ago, and some have, including some of the speakers and panelists that you'll hear from today. Before I thank a few people and introduce Dr. Hellerstadt, a few housekeeping items. One is the restrooms are out here to the right, for those of you who are in person. Also, for those in person, we'll have runners for the microphones during the panel discussions and question and answer. Please use those microphones so the people who are joining us virtually can hear all the questions. My script actually says, please wait for the microphones so that virtual people can hear the questions. The people are actually real. They're joining us virtually. For those of you who are joining us virtually, for those of you who are real and joining us virtually, please use the chat for your questions and we'll try to synthesize and get as many topics as possible. Finally, please be aware that this meeting is being recorded and will be posted on the TEPHI Texas YouTube channel. The Public Health Summit is a collaboration between the UT Health School of Public Health and the Department of State Health Services. This year, because of the topic, it's also a partnership with the Texas Epidemic Public Health Institute, which is charged to help Texas better prepare for future infectious disease outbreaks. I would like to give special thanks to Dr. Carlos Plasencia, Medical Director of DSHS Region 6-5 South. I've had the honor and benefit of Dr. Plasencia's compassion for the people of Texas and his wisdom throughout this pandemic. Dr. Plasencia and his team played an integral part in planning this summit and brought a very important and valued practical perspective to the agenda. Now it is my great pleasure to introduce Dr. John Hellerstadt, Commissioner of the Texas Department of State Health Services, who will open today's meeting. Dr. Hellerstadt earned his MD degree from the University of Pittsburgh and completed pediatric residency at the UT Health San Antonio. After multiple years in practice and public service, he accepted a position as Vice President for Medical Affairs at Dell Children's. He became the Associate Chief Medical Officer at Seton Family of Hospitals in 2009 and the Chief Medical Officer in 2013. In 2016, Dr. Hellerstadt assumed the role of Commissioner of the Texas Department of State Health Services. With his leadership, the agency strives to achieve the vision of a healthy Texas and fulfill the mission of improving the health, safety, and well-being of Texans. He has many honors and awards that I will not list in total, but I do want to mention one of them in particular. In 2007, he was named Texas Pediatric Society's Child Advocate of the Year. Commissioner, I can't think of a higher calling and I can't think of a greater honor. Thank you for your service. So please join me in the room and virtually in welcoming Commissioner John Hellerstadt to the podium.
Thank you very much, Dr. Borwinkle, for that kind introduction. And I have a number of slides to present, and I'm going to go through them fairly quickly and really just try and pick out the primary points there. And I'm sure they'll be available for your reference after the talk. So I am the commissioner for the Texas Department of State Health Services, and it has been a particular honor to have that position, but it has been especially a deep honor for me to be here during the pandemic and see the amazing work that public health in Texas has done. This is, I think, one of the major themes for me, and that is that here we are today at this point in the pandemic. We are still a highly functioning society. That was not a guaranteed thing at the beginning of the pandemic. And we're set to really prosper and eventually, I hope, put the pandemic behind us completely. That is an amazing thing. But as I think we'll be talking about in terms of communication, it's not just about the science of public health. It's about society and society's understanding of public health and society's willingness to take the steps that are needed. So I'm going to, here's what we'll be going through. All these numbers move, so whatever is written here, I can guarantee you that it's higher today than it was on the date that's listed. Right now, we're looking very carefully at hospitalizations. It's one of the things that we paid the most attention to early on. Why? Well, hospitals are a precious resource. You can try and expand their capacity, but it's not easy to scale up and suddenly create lots and lots of new inpatient space. And it was also one of two parameters that we had where the denominator was the entire population of the state of Texas. One was the number of hospitalizations and the other was fatalities. So we had the testing, and that gave us an indication, but the testing was always a sample of what was of the population. It wasn't the whole population. So the testing was, if you will, a leading indicator. The hospitalizations were something of a lagging indicator, and the fatalities were a lagging indicator, if you will. But you can see there that total number of fatalities, that is quite a remarkable number, 87,000. That's more than we had in one of the, nationally, in one of the worst flu seasons that we had a few years back. And this is just in the state of Texas alone. So our trends so far, the way we count it, we've had 4 different surges, and each of these was associated with increasing numbers of cases and increasing hospitalizations and fatalities. We're now continuing to see an increase in the number of reported cases. We get about 30,000 plus tests of the PCR type test a day, which is really quite remarkable, but that's down from the peaks that it was before. So here's our new cases, and I'll show you this. You can see the peaks. And what does it tell you? Well, for one thing, when they're looking at that peak that is right there around January of 2022, that was Omicron. And so here again, we had an enormous testing capacity, and people went out and got tested. Whereas what we'll see in some of the other things, for those earlier peaks, there was more morbidity that was on the same scale, if you will, as the testing. So here really is the hospitalizations, and I think of that as the disease load. I could spend a lot of time on these. They're quite fascinating because although they all look like peaks that are pretty similar, they're all subtly different in different ways and presented different challenges. But you can see here in the most recent trends, we're seeing an upward trend in hospitalizations, which is telling us that it's circulating in the community. It is still making people sick. And of course, the newest variants that we have out there are remarkably contagious and remarkably capable of breakthrough infections for people who've been vaccinated, and then reinfection for people who had recovered from earlier versions or earlier variants of the virus, which presents a really, I think, among other things, a real communication challenge to folks who are tempted to say, well, gee, your vaccine doesn't work. Well, it turns out there's nothing that is a 100% guarantee, and there never was. But all of the things that we can do, including folks in this room being very aware of the value of masks, for example. I bet you're all very aware of the value of vaccination as well. And so you are taking steps to minimize not just the risk for yourself, but the risk that you would contract the virus and replicate it. And it's through the replication of that virus that the variants emerge. So trying to suppress the amount of that virus that's in the community, it has many, many values. So here you can see hospitalizations. Here you can see fatalities. I want to talk about the coordination and resources. This is a great example, I think, of where part of what we do in public health, governmental public health, if you will, is we need to know the public health science, but we're also out there in the field doing things in terms of supporting the community. So medical staff surge capacity. Hospitals became fatigued. Hospitals, many of them had extra rooms that they could open up, but they needed staff in order to do so. And so we, through our contractors, were able to provide that staffing. It was really rough, and you can see the numbers there. A total of 30,000 staff provided over the period of the pandemic. We also had to deal with durable medical equipment and consumables. We had to do a lot of coordination. We had to do a lot with the vaccine. So suddenly, we were not only there to be experts in the public health science, but we became experts in logistics in terms of having to integrate all of these different systems of ordering and allocation. That was very challenging, and I am especially proud of our agency of public health across the state of Texas for being able to pull this off. It was not easy. And for every one of those things listed there, I guarantee you there were about 100 different problems below it that had to be solved. Now we have vaccines that go all the way down to the age of 6 months. We're seeing modest, if you will, uptake of vaccines in the younger age groups. I hope we can continue those trends. One of the things you'll see here is the mentioning about people, the percentage of people that have gotten their primary series. And I will tell you, one of my little peccadillos, if you will, is people sometimes term that fully vaccinated. That legally is correct, but I much prefer the talking about them getting their primary series, because we know that just that primary series alone is not anywhere near as good as getting your first and second booster. And I did all of those things. And then if you look at the last line there about how many people have gotten boosted, we can be pretty proud, for instance, there, that one thing of 86% of adults 65 and older completed the primary series. Hooray. But those are the very people who need those boosters. And the numbers there were not broken down by age, but go figure, the percentage of people in that highest risk category isn't nearly what I hope it would be. We also had to deal with the therapeutics, monoclonal antibodies, and come in different varieties. I think you're probably aware of those. There's antiviral treatments for high-risk folks. DSHS supported some infusion centers that we had around the state, and they were very popular. It was very interesting to see, if you will, kind of the uptake, particularly of monoclonal antibodies, where initially, I don't know, people weren't necessarily all that thrilled about going in and getting an IV infusion. But I'll tell you right now, that is the preferred treatment for many folks who are positive. Their personal preferences, I should be clear about that. So lessons learned, holy cow, we could really write books about that. And again, I would say the biggest lesson to me is that it's about society, not just about the science. It's going to be going forward in the future. It's going to be about explaining some very basic things, for instance, about the pathophysiology of and epidemiology of respiratory viruses, how they're spread, how you can protect yourself against them. So the communication piece was major, because after all we can do in a free society such as ours is recommend and try and persuade and convince people that the recommendations that we're making are sound and that they're going to provide them with some protection. When the vaccines rolled out, making it easier for providers to enroll, because we have a whole system called the Texas Vaccines for Children system and the Adult Safety Net. But for these special COVID vaccines, they had to make a special enrollment. So there you go. That was another, if you will, paperwork hurdle that people had to cross. The packaging early on was sometimes a barrier for folks, and the 2 vaccine series presented a challenge because, again, initially the idea was you were going to get vaccine A for your first, you were going to get vaccine A for your second as well, until we kind of learned to mix and match. Vaccine confidence, as you know, a lot of people just didn't have it. And then there were also the vaccine reporting requirements, which were quite robust. But that was necessary. It was necessary to have all of that information. Lessons learned, the rapid and continuous evolution of COVID vaccine clinical recommendations was a challenge. Vaccine hesitancy, misinformation, and disinformation that was out there was also a barrier. Our best practices were to really kind of engage stakeholders. And I want to make a special mention of our EVAP, the Expert Vaccine Allocation Panel. We had 17 folks on it, experts in public health and virology, in clinical medicine. But one of the very valuable contributors to it were 4 senior legislators, 2 each from the House and the Senate. And they worked really hard and stuck with us and went through all of the data that we could present and all the science that we could present. And I think they came away genuinely respecting and understanding the role of public health science in a way that they hadn't had before. And it was their job to say early on, when we had a very small supply of vaccine and a very great demand for it, well, what populations are we going to prioritize to get it first? And the fact that we had that kind of open discussion, I don't know if other states did it or not, but it certainly worked really well here in Texas. I think the public had great confidence that that there was transparency here, that people that they trusted and elected and had the authority to weigh in on these kinds of decisions were part of it. And that is extremely important. And of course, we always reach out to stakeholders. We would always have meetings with those kinds of folks. We had to go through, again, a lot of logistics in terms of handling this massive new logistical challenge that we had. Again, early engagement with the manufacturers, having to try and have direct conversations with them. We did our best for the vaccine allocation and distribution. It was not without difficulty, right, Dr. Schufert? It was quite a challenge to do that. All of our staff got to have take their turn at that and the distribution for pharmaceuticals and therapeutics as well. Next, I'm gonna kind of go through this fairly quickly. Again, you can have these slides for your reference. Here is a term that I use. I call blindsight. Everybody is familiar with 20/20 hindsight. So, you know, after something takes place, you look back in 20/20 hindsight, and you have a very clear understanding of exactly what happened and why it happened, and you're smarter for it. The inverse of that, if you will, is blindsight, where you look back at what happened and you misremember, or you do not understand, or you misinterpret what happened. And I really, this is one of my biggest themes in terms of going forward, and in terms of our leadership and our populace seeing and understanding the value of public health and what it has to contribute. After all, again, here we are, we're very successful. I know not everybody, but some people are saying, why did you make us do all these things that we didn't want to do? See, it all turned out okay, right? You must not have really known what you were talking about. We know that if you go back to those peaks where the hospitals almost ran out of capacity, we know that we came very close in many instances to running out of that capacity, which I think would have caused a great deal of harm to society, because people who would lose confidence in the ability of the system, of the healthcare system, to provide them with necessary care. So again, this was very complex. I think one of the things that was helpful for me and for Texas was I'm a firm believer that science, including public health science, can advise, but science can't decide policy, because all of the things that we did throughout the pandemic were balancing two things which were good in moderation, but which, if taken to extreme, could have been extremely harmful. What do I mean? Well, one is, what's the best way to protect yourself from a respiratory virus? Stay home. Don't go to work. Don't be around other people. Guess what? Suddenly there's no food on the table, and you have collapsed the ability to support the society. Clearly a catastrophe. If, on the other hand, you'd have said, oh, don't worry about any of this stuff. Go ahead and go to work, socialize, go to bars, hang out in concerts and all that sort of thing, we would have condensed all of the morbidity and mortality of the past 2.5 years into maybe 6 or 8 months. And for sure, we would have broken through our capacity to provide that inpatient care, not just for people with COVID-19, but for women delivering babies and 5-year-olds that need their appendix out, and families that have been in car crashes, and people who need stents and things of that nature. You know, nowadays, inpatient care it may not be emergent at all times, but it is often very much urgent and necessary for life-saving or limb-saving treatments. So balancing that, again, in Texas, I think it was clear when I would be in news conferences with the governor, I was providing recommendations. The governor was issuing executive orders and making policy. And I think that stood us in very good stead. And unfortunately, I don't see that model was something that came from the national level on down, and that left a lot of room for miscommunication. So again, the pandemic, going back through it, some of us who lived through it sort of have PTSD a little bit when we go back and relive some of these things, and the stress that was there, especially when the demand for things went through the roof and the supply wasn't there. For example, just in PPE. All of a sudden at the time, you wanted as many masks as you could find. The demand went through the roof and the supply dropped to zero because they were all made overseas. The variants, I think, are a real challenge as well. I'll overstate this, and for those of you in the audience who are really virologists and scientists, you'll hold it against me. But the variants that we have now behave so differently than the parent virus did that it's almost as if it is a different virus. I think I think we need to take a real hard scientific look at that. So really, thank you for your attention. I think we're going to have a great meeting. Thank you very much for inviting me here. And my next duty here is to introduce Michael Macart. It's my pleasure to do so. Dr. Macart is the director of the Center for Health Communications at the University of Texas at Austin, and he holds faculty appointments in the Department of Population Health and the Stan Richards School of Advertising and Public Relations. His research focuses primarily on the strategies that can be used in traditional and new digital media to provide effective health communication to low health literate audiences. He leads projects on the variety of public health issues, including tobacco cessation, opioid overdose prevention, and the men's role in prenatal health. He is the author of more than 100 peer-reviewed journal publications and the book titled Designing Effective Health Messages. The title of Dr. Macart's talk today is Supporting Public Health in Texas with Evidence-Based Health Communication. Please join me in welcoming Dr. Macart.
All right. Well, thank you for the warm introduction. It's such a exciting opportunity to be with you here today, talking about sort of health communication. I could talk about health communication all day long, and so it's an exciting to have kind of that be the big topic for today. There's a few things I was hoping to kind of do with y'all. Is one, just share a little bit about health communication and the work that our center at UT Austin does, and some of the tools in particular that we use in developing more effective health messages that I'm hopefully you could like immediately take back and adopt into your own work really easily. They're things we use all the time. I didn't want to make my talk the COVID talk, but I did want to share a couple notes about what we were doing, sort of especially in those early days of COVID, because it was pretty different from what state health departments were doing, what a lot of people around the country were doing. Wanted to share a little bit of that, and then finish with a case study on a very different health issue, showing the way we work through kind of the cycle of developing and implementing a health communication campaign and the way we sort of follow our evidence as we go on a completely unrelated topic to COVID. But background about me, I did not get into health comm on purpose. A lot of people who do get into it because they want to use their interest in communication to support people's health. I have a bachelor's in chemistry. I just happened to have the right advisor who picked my name out of the grad school application, and I fell into telemedicine. And the very first project I worked on was delivering hospice care by video phone. And this was like 2001. It was like tiny little, telephone screens running over copper phone lines. And I just fell in love with the chance, like that program really helped people kind of have quality end of life care in a really meaningful way. And I fell in love with it. And the last work I was doing in grad school was all around health literacy and how can we make information really accessible to people who might struggle with health information. And so when I was on the job market, UT Austin had this job posting in advertising. I didn't know anything about advertising in particular, but it was a school I wanted to work at in a city I wanted to live in. And so I decided to take a shot on it. And it was the best thing that could have happened to me in my career because a lot of the telemedicine things we were doing were built on an education framework. Like if we make it really easy for you to understand diabetes, of course you're gonna make great health decisions. And so I landed in a field where it's like, my advertising colleagues might not really care ever if you know why you do anything. And so thinking about that balance of education and persuasion became really important. It was only through the job I happened to land first. And so I started digging into drug advertising. Because if I cared about health literacy and I wanted to keep a job in a school of advertising, this is like a logical thing to look at. And one of the critiques of kind of drug ads is they use emotional appeals to drive someone to kind of ask their prescriber for a very particular drug, whether or not it's the right one for them. And that has implications for patient-provider communication. But I always thought it was an interesting critique that like this emotional appeal was what people were upset about. Like I teach my students how to use emotion to sell dish soap. And if we take it out of sort of the commercial market of drug advertising, like no one has ever complained about the Truth Initiative using emotional appeals to prevent young people from starting smoking. And so the way I really started to kind of think about my work, kind of just this random path I followed was how can we take these tools and techniques of persuasion and advertising and put them in service of public health? And so I start every talk like this kind of defining health comm the way our center defines it. Because if I go to a conference that's filled with a lot of clinicians, what they think health communication is, like as a starting point, is always patient-provider communication. Or if I'm at a public health conference, you're thinking this is your brain on drugs. And so I always want to kind of highlight that the way our center thinks about it is kind of it's both the science and the art of using communication to support the health and well-being of people, the populations. So sure, it is patient-provider, but it's also how do families communicate about health? Like how do people communicate about health on social media? Where do they find that information? How do we develop more effective health comm campaigns? And so the science piece is particularly important. A lot of people think of communication as sort of a soft skill. It's squishy, you're good at it or you're not. Or like that person, like if I'm really outgoing, that means I'm good at communication. You all know at least one person in your life who is very outgoing and also a terrible communicator. And so one of my faculty colleagues studies how do you break bad news? Like there's a best way to do it. She can train you in it. You can get better at it. There are decades of health communication, literature, theory, research, evidence. There's a science to it. And so we really think of ourselves as the evidence-based health communication center, like it's even on my water bottle. And we think of our work in three big buckets. Part of it is certainly research. Like there are faculty, as far as we know, we're the only academic center for health communication in the country that is jointly shared between a college of communication and a medical school. And for every project we do, we're pulling in our colleagues from public health and pharmacy and nursing and social work to merge with communication and kind of have that balance of the team. So we do lots of work that is designed to kind of support health comm research and kind of advance what we know. On the education side, 3 weeks ago, we hosted an event in Austin that is attended by people from the CDC, state health departments, hospital systems, nonprofits, to kind of get training in health communication best practices and how to be a health communication leader and advocate for the field. Like too often communication in public health and medicine, it's like, we did a project for a year and at the end we bring in the PR person and tell them what we've been doing and then fix something usually. And so how can we advocate for communication to have a seat at the table all the time? Because all the work will be better for it if that's the case. And on the practice side, which I'll be able to show you a lot of today, I often tell folks in a lot of ways I have kind of stumbled into running a really highly qualified health ad agency that is hiding at UT Austin. And so we do a lot of work kind of in partnership with DSHS, MD Anderson, UT System, all kinds of external funders to develop, implement, and evaluate health comm campaigns in the real world. Like it's really fun. I have a great team of designers and copywriters and kind of program people who help make it happen. And it's like easily the most fun I've done in my, most fun thing I've done in my career. And I'll show you some examples of that today. If I'm teaching my advertising students how advertising works, or we think about the health comm work that we do, it's a 4-step process. It's not nearly this linear, but we think of developing really good messages as it starts with research, which you all in this room are really familiar with. In the health comm context, that is, how have other people tried to solve this problem? Like, what do we like? What do we not like about how they did it? It's surveys and focus groups and all the ways we would kind of think about research. The end result of that is a giant pile of data. It is really hard to build good communication on a giant pile of data. And so I think the hardest step is this insight step where it's like, what are 5 or 6 things where it's really important to our intended audiences, where communication can make a difference? From there, you think strategy, like who are we talking to? What do we want to say to them? And then finally, tactics. What does it look like on social media, on a billboard, TV ads, all those things? Everyone jumps to the last step first because it's fun. Like, what's it going to look like on Facebook or Instagram or TikTok or whatever? Like, if you don't know what you're saying first, like TikTok might not make sense. And the example I really love to share here is the original Got Milk campaign. For decades, milk was sold as like a health drink. And, you know, in the 80s, it was like people wearing 80s bad workout gear, like chugging a carton of milk after going for a run. And milk sales all around the country were going down. And the California milk people were like, they went to an ad agency and said, we want you to sell more milk. We don't care if you just like convince people to buy more cereal. Like do whatever you need to do to sell more milk. And the ad agency people were so excited. They're like, smart clients get the best results. And they went out and they did all the research. And there was one focus group approach they took in particular that gave them the insight that really drove that whole campaign. And so they invited people to focus groups and they said, we'll pay you extra if you don't use any milk for the week before you come in for the focus group. So what people heard was, I'm not going to drink milk for a week. They showed up after a week of not using milk and they were angry because they said they weren't thinking of the fact like no milk means my coffee's not any good. I can't eat my cereal. One of the people said she had the world's worst day at work, stopped to buy a chocolate brownie on the way home. And then she got home and was like, the ending of this day is even worse because she felt like she couldn't enjoy that brownie the way she wanted to. And so the insight they got was, it's not drink more milk. It is the absence of milk is terrible. And so that whole campaign was, do not run out of milk. And in California, sales of milk went up. The whole rest of the country continued to go down. And eventually they just licensed the campaign to the whole country. And it is only in hindsight that don't run out of milk is more effective to sell milk than you should drink more milk. But then it's like, oh, that makes lots of sense. And a lot of really good comm is like that. It is only obvious and smart in hindsight and not kind of in the moment when you're in the middle of a pandemic, for example. This is something I love talking about, especially with kind of a more public health audience. How we frame our messages matters a lot. So the building I used to work at in communication, 7 floors, everyone would walk in on what was the ground floor, but was technically the third floor. So people are already kind of confused. What floor are they on? The elevators were just a disaster in this building. And I would always have my classes on the top floor and I'd say, this is annoying to me. I want you, my students, to get more people out of the elevators and into the stairs as an exercise in my class. And what they would always do, almost all of them every time, was think about health messages. Like you'll be healthier, you'll burn some calories, all the things. And I'd let them do it for like 15 minutes and we'd talk and I'd say, how many of you knew that before we started the exercise? And they all raised their hands because they all know it. I'm like, how many of you took the stairs today? No hands go up. And especially in a public health audience, like I love you all, but like you think about public health and the specific things you work on a lot, all the time. It is impossible for you to think about it like a normal person. And often you want people to make the right, like we all do, we want people to make the right health decision for the right health reason. So we tested this. I had a really good PhD student. Sorry, this is what she wanted to study and build an experiment around. So she designed these. These are good, like nice looking messages like take the stairs, it's the healthier thing to do. We also built, and this is like way pre-COVID, so like that wasn't a reason. But like in Texas, like why else would you not want to get an elevator? It's slower. It's like not always fun to be in an elevator on campus with a bunch of sweaty other people yelling on their cell phones. Like an elevator is not a pleasant experience. If you test these on campus, the ones on the right do better. They get more people taking the stairs. It is also more effective if you put them 100 feet in front of the elevators. Like as humans, once you push the button, you'll stand there until you die. And so like, it's not just the right message, it's the right timing for the right message. And so a lot of the ways we think about good comm is like what actually matters to our intended audience that will get them to take a good health decision. I'm never gonna lie to someone to get them to take a health decision or support their health, but I can think about what else might motivate them that isn't the thing like I would think should be their motivation. Like I wanna hear them and give them what they actually want. This always feels a little corny when I show it, but I swear this is how every ad agency does it. It's using personas to represent the audience you're trying to reach. And I try really hard, I don't always nail it. I try really hard never to say target audience. We work really hard to say intended audience because it's a good reminder that you are trying to reach particular people. You're not going to reach all of them. And there are also unintended audiences for everything you're doing. So I don't always do it, but like this is, I try really hard to do it. And so 1 year on campus, my ad students are doing a project in partnership with the campus health office, and they wanted to skin safety. So do use sunscreen, don't use tanning beds. So my students spend a month working on this. And this is how one team like that, this is like a direct copy and paste off their slides. This was their target audience. And they said it's members of sororities on the UT Austin campus who are 18 to 22 years old who use tanning beds. Like, they're not wrong. And they developed some messages. And then the team after them got up and did their presentation, and they did it the way I had coached them to, which was to use a persona. And they said, our intended audience is Rachel. And she's a Chi Omega, and she drinks Starbucks, and she shops at Nordstrom. She like stays fit, eats healthy, goes to a dermatologist, is aware of the risks of UV tanning, but she believes it makes her look thinner and have better complexion. Like, you can't tell Rachel, like, don't do this because you'll get skin cancer someday. She already knows. You can think of other things that might persuade her to not do these things. And so if you develop and think about talking to Rachel one-on-one, you can build a health campaign that will reach a lot of people who are a lot like Rachel. And so it's not perfectly representative, but sort of a tool to think about messages that might work. Y'all remember the Verizon Can You Hear Me Now guy? He was like walking through the woods. Can you hear me now? Can you hear me now? Every campaign we do, we try to get down to a single sentence. Like, what is your campaign trying to say? And if you can get it down to a single sentence, I'm going to argue you actually know what you're trying to say. And if you can't get it there, you're not there yet. I talked to the creative team in New York that built that campaign, and they said for Verizon, the Can You Hear Me Now guy, it was a single word. What can anyone want to shout out what you think the word might have been? It was one word guided that entire campaign. Now, what else? I hear people saying good. Like a lot, I heard someone I think say speed. Like one of the things that people tend to think the answer is like they describe a good cell phone network. It's fast, it's reliable, has good coverage. The word they actually used was relentless. What that campaign was saying was, we are working harder than the people at AT&T and Sprint to make our network the fastest, the most reliable, the best coverage, all the things. So if you're in an area and we don't have good service, like, please forgive us, but we're working harder than those other people to make it better. And so every single ad they did, if it did not communicate relentless, they redid it. Coors Light, their word is basically cold. Like, every single ad it's about cold. People think Coors Light is colder coming out of the same refrigerator as other beers, because all they do is say cold, and it's really effective. And so that kind of consistency is really, really important in health communication, especially since a lot of times our public health campaigns do not have the budgets of lots of commercial entities. So we have to be extra consistent thinking about what we're saying to make the biggest impact we can with the messages we're able to get out there. A huge part of what we do when we talk about following our evidence is following our data where it leads us and checking our assumptions. So one of the projects I get to lead at our center, it's called Father's Playbook. It's supported by the state, and it's about getting dads involved in prenatal health and early childhood. But it began life as just a personal research project, because when we were expecting our first child, my daughter now, I downloaded My Pregnancy Today. It does so many things really well, but the whole time I'm like, this app was clearly not designed for me. And I wanted to think about, if we thought from scratch about what good health comm would look like for an expectant dad, what would it look like? And so My Pregnancy Today has very much your baby's as big as, all the things. Well, we're like, well, for ours, let's try sports metaphors too. So this is a website that is about 7 years old now. And we created Your Baby is as big as, with the fruits and vegetables metaphors, but also with sports stuff. We tested it with a bunch of guys nationally. The food metaphor wins, 60-40, 70-30, which I was already surprised about. And then we asked why, and they said it's because it helps remind us of the importance of proper nutrition during pregnancy. I was shocked. If we hadn't done the research and tested it, we for sure would have done the sports thing. And so instead, we checked our assumption, we tried it, we went the smarter direction. Similar example, some of the state-funded opioid work that we do was one of the videos we were creating was going to be around how do you get people to talk to someone they might be concerned about? And one of our interpersonal health comm postdocs, she said, there's these family communication patterns that might matter a lot. Some families are really direct, and they're going to be like, I am worried about you misusing opioids. Other families are much more indirect. And it'd be like, I was watching a TV show last night, and this person was misusing opioids, and kind of look sideways at a person. We tested that to see, does it matter how we depict the conversation in the video if we can get people with different conversation patterns to engage more? We were basically worried if we showed a really direct conversation, are there people who are gonna be like, I could never say that to my partner or my kid. I just can't do it. It turned out it didn't matter. But we thought it might, so we wanted to test it and be extra sure. So a lot of this is always kind of testing our assumptions and kind of following us where our data leads us is really, really important. All right. So when COVID hit and the whole world shut down, I got a lot of emails from people, and they were like, what are you going to do with the Center for Health Communication? And our team actually doubled in size during COVID. So when COVID hit, we had, a couple designers, our team has 10, 12 people. Now we're at 20 some. I was like, and as I was watching every local health department in the country create a 6-foot social media, 6-foot graphics and all the things, right? I knew the answer was not for us to create one more of everything. And so we started as a team thinking about what we could do that would add value. And so one of the first things we did was we created a Twitter thread. Yeah, there we go. We went out and found messages that we liked that already existed and talked about why we like them. So this one on the left, which is, I think it's a stock photo from a really bad cell phone ad, but then they adapted it for COVID-19. And we talked about why this was really good because it was helping raise perceived susceptibility, health belief model, for young people who might not be thinking about why they're susceptible. And so we just created this thread of we like this one and here's why. And that felt more valuable. If there's anything I could do to help the country be more prepared next time, it would be a better system for quickly testing and sharing messages that work. The volume of, I don't want to say wasted labor, but replicated labor to develop some of these things over and over and over and over again, all in parallel. We could have done it better, and we could have helped the best ones spread. Also in HealthComm, you don't have to reinvent the wheel from scratch. This was a message we found from Washington, D.C. And like, there's nothing on this really that is about pregnancy. But because it's about pregnancy, you might have some pregnant women who would be more likely to pay attention to it. Like, that's part of the goal of it. We just stole the content, credited them, and then made it for expectant fathers. Like, there's no reason we can't do this. This was really a lot easier than developing our own thing from scratch. We like the idea. Like, let's copy, adapt, and help it spread. Like, this isn't a commercial, like, it's not Pepsi stealing Coke's ad. Like, we can work together a little better to kind of help good things spread. The other thing that happened was in kind of June. I know, I love this dog. In early June, we got a request from UT if we could help support kind of UT's comm heading into the fall semester. And so if we learned anything in that process, it is you can do health comm real quick when you have to. And so we did 17 focus groups in 2 weeks with faculty, staff, and students. And this, I love this little guy because he was, I mean, this was June. So I think it was maybe Western Illinois University. This is their mascot. They put it on. We were asking people, we were really curious about tone of the COVID health comm coming out of UT. Like, how should we do this? And people in our focus groups, students, faculty, staff, the first bunch, all kind of liked him. They were like, oh, like that cute little dog's wearing his mask wrong, you know, like, but like everyone liked the tone, like it felt about right. And so as we worked through the groups, we photoshopped a mask onto Bevo. I can't express how much people hated this. It was 2 groups. People were real angry at us. Like, and it was like, we clearly photoshopped this, but like people hated Bevo in a face mask. And we did the 2 groups. And at the end of the second one, my postdoc, she's like, we're going to stop showing that to people, right? And I was like, oh yeah, we are. And so one of the things that we, like, good health comm isn't always saying the right thing. Sometimes it's avoiding saying the wrong thing or little subtle adjustments. Like UT in the early days was very much, and students really got it much faster than I would have expected. Like, it's about not, it wasn't only about not sort of harming the old professor in the front of the room. Like, they went really fast to like fellow students who might have cancer and they don't know it. But one thing that everyone was really clear on was the university had to talk not just about protecting people who were vulnerable to COVID-19, they had to add, and people made vulnerable through their work at the university. Like, faculty, staff, and students were adamant that like that was really important. If UT was going to be communicating, they had to add that bit of like empathy and understanding that like they were making some people come to work who were going to be more vulnerable as a result. And so we were able to pass this along to the university, like on an almost daily basis. We were handing our focus group findings to the university comm team. And so what we did was incorporated into the campus-wide kind of kits, but also we advanced health comm research, like literature, because the idea of like, why do people like the bulldog in a mask and hate Bevo in a mask? Like, the editor of the journal Health Communication was like, that's super interesting. And we were able to get like an academic article published on these focus groups that we did because the university needed us to do it. And so it's a way that we can really kind of put together good health comm research and practice and kind of move the field forwards. All right, last thing I'm going to share before we head into a panel is this little mini case study on how health comm works when we do it and do it well. And the university UT system came to us and said, every UT campus does high-risk drinking prevention work. So like, don't drink too much, you know, all that work. And they all do a really good job with it. All the campuses also do like a lot of sexual assault prevention work. And they do that really well. Those 2 campaigns never intersect. Like, the people actively were avoiding it because it is so easy really fast to become victim blamey. And so it's like, it's really hard to get the comm really well. Everyone just kind of tried to keep them separate, even though we know in reality they're really together. And so they asked us to do a 3-year project on how to help communicate more effectively and help students understand the intersection of alcohol and sexual consent. And so this project, we had an entire year to do formative research. No one ever gives us that much time. It's really good they gave it to us for this project because it was really complex. It includes one of my favorite ever research things we've done. We created what we internally call our trunk scale. So we had some UT undergrads. Imagine this stacked up. This is the BAC chart. And we asked our undergrads, we said on the left, we took all the numbers off and said, what would you call each level? So totally sober, loose, buzzed, all the way down. In the middle, physiologically, what is happening to you? On the right, like, what does it actually look like? And so if you're feeling it, your judgment and self-control are lost, motor skills are impaired, and balance may be compromised. What it looks like in the real world, dance like no one's watching. Oh, you've already been doing that. Do not get behind the wheel. So I want you to take a second and look at this, because the question we asked students, UT Austin and UT El Paso were our two pilot schools. We asked them, where can you be on this scale and give or receive consent? We were doing a lot of the early data collection pretty under the radar, because we knew like we were gonna say and do things and develop messages that weren't gonna be right. So we were a little under the radar. The story in our data, really, young male identified participants in our sample, on average, exactly 1 drink higher than the young females in our sample. So when we think about where that insight is that can drive behavior change, if we can help students on the campuses understand there's basically a 1 drink gap, like that's where comm can make a really important difference. And so everything we do, we develop lots and lots of messages, and then they slowly disappear as we test them. We were doing this part of the work during the Kavanaugh confirmation hearings. And so one of the fears like the students had working on it too was like the number of people who wouldn't even want to hear what we were saying to them. So one of the messages they wanted to develop was a very like Humans of New York style, anyone could be a perpetrator, anyone could be a survivor, like invite everybody in and then let's do the hard comm work we want to do. Like that was a student-driven idea. We asked students in surveys and interviews, how can you tell if someone can give or get consent? 3 categories: how they're talking, like can they physically move okay, and eyes. Eyes was like its own category. So we took the words students were giving us and how they make the judgment, and then turned that into kind of what consent kind of looks like or doesn't look like. We developed 2 ideas around like all the students were like, this is a 2-person conversation. And they were really aware that even 2 pretty well-intentioned people might miscommunicate and might not hear each other and communicate really effectively. So we wanted to show this kind of 2-sided conversation idea to see if that might be kind of the winning idea. We knew that this was not how it would eventually look, but because our early data was very like cis heteronormative, like this was the most direct literal translation of that drunk scale finding. And so it was your drunk is her totally wasted. And I'll show you how that one evolves because it definitely moves a lot. But that was like a direct translation of that insight into kind of a message. This one says, you might lose your keys, but don't lose trust. We were really curious as we talked to people, like, would this be a trust building conversation? Like if you meet a person at the bar, it's the first time you've met and you start talking about the intersection of alcohol and sexual consent. Is that good? This person gets it? Or is that, I am now scared of this person that's like the first thing they want to talk about on day one? Like we really didn't know. Overwhelmingly, a trust building conversation. Like students said they want to have it. They thought it'd be a good thing. We want to make sure all the students know this is going to be perceived as a trust building conversation. And then the last thing again, it was very intense. The students themselves were telling us, please do something that's not heavy. And so I had students working on a class project. I just directly ripped off one of their ideas, made it look a little nicer with a professional designer, and had like an emoji themed idea. As soon as you put that UT logo at the bottom, students see it and they're like, you are an old person pretending like you're young. And it was developed by students like a classroom over. Like it is a student generated idea, but the logo radically changes how people see that ad. So like that one went away really fast actually. So we like do a little bit of revising. This 2-sided thing stays, that stays. This was our next attempt to do something light. Because we're thinking if alcohol and consent are related, like we want to connect them as like a pair in people's brains, like what are other classic pairs? So peanut butter and jelly. I'll tell you, this is like the most ridiculous series of conversations I've ever had at UT. Like there was like a vice president for like student affairs being like, well, why is like jelly concussed? And that donuts chasing that little donut hole. It was just like a lot of really ridiculous conversations, but it was really fun to work on. And all the students on campus have like the little tchotchkes hanging off their backpacks. Like there was a lot of potential for this one to be fun in the real world and be that lighter idea. Here you can see how we are changing the pronouns, changing the colors. I learned a lot about VisCom in this project. Like I have a former student who was helping with this and she's like a visual, like that's what she does, like visuals in health communication. There are almost no colors that we do not code by gender. And as UT system, all the colors have to be friendly with a mainly like orange, blue, reddy kind of palette. And so we were talking about that a lot. When we changed it to you're buzzed, is they're totally drunk, it flipped it for the students. This was like unintentional, but good. We were thinking of it for a while as like potential sexual partners. As soon as we did this, it's like, oh, I want to check in with my roommate before we go out tonight. I want to debrief the next morning. Like, it created a peer conversation angle on it that we did not do on purpose, but was really good. And also students were like, can you just please tell us the magic words we should use? And so we created what we were calling flashcards, where it'd be like prompts, like here is a question, here's an answer. Here's a sample like sentence you might use. We were envisioning that these could be turned into coasters and like put in the bars downtown, put in frat houses, put in sorority houses, put in all the places where this is going to be a relevant thing to get out into the real world where it matters in the moment. We did one last round of revisions. This one stays the same. Here you can see, we made the jelly look less concussed. We added little red solo cups because we really needed people to understand this was about both. But also it's like, they can't be having too much fun because UT never wants to seem like, or like system never wants to be like encouraging drinking among undergrads who are not yet 21. So it's like, how much quesos falling out of that bowl was like an active conversation we had. You can see here, we added alcohol, like we added beer to the visual to make it more obvious. And in one of the visuals, like there was one that had the alcohol at the same level. Because we wanted to make it really clear, like my one glass of wine is not the same as your one glass of wine. Like that was like an important kind of message or component of that. And this one stays the same. So if I could really quickly, I only have like one or two things left, just show of hands in the room. I'm curious, who thinks the two-sided conversation ends up winning when we test it? Any hands? On the far left, it's like I said this and she said this and like that back and forth conversation. I just see like shaking heads. Okay, classic pairs, peanut butter and jelly. Who thinks that is the winning idea we end up going with? I see some hands. Okay, we called them our PEG people. Our PEG people idea. So you're drunk is they're totally wasted. Show of hands. Okay, that's the winner so far. And then flashcards. Anyone think the flashcards? Okay. So the results are, because we do, at this point, we're like doing bigger surveys of students on both campuses, and we can show different students different messages and then be able to kind of see which ones actually achieve different variables that we care about. So when we show the two-sided conversation idea, it does better at UTEP than at UT Austin. And at UTEP, students who see this one express higher intentions to communicate about this thing. Like, that's a winner. We're excited. That's one of the variables we care about. This, oh no. This does great. If you had told me like 16 months before we got to here that I would show anything to students, and we moved them down the drunk scale. Like, students who saw this, like, thought you couldn't have as many drinks and still consent to sex. Like, we were like, okay, we won, like, we're great. People think it's only about alcohol, so the communication part wasn't as strong. People hate this, which is a real bummer. And we had this message called tone. It was like, what's an ideal tone for a campaign about alcohol and consent? What's the tone of this campaign? The other three are all like right about where we want them. This one just is like, nope, absolutely not. We honestly don't know. Like, either students say they want it lighter until they see it lighter and then decide they don't like it, or we just never had the right like lighter idea that would have achieved that. So either way, like, we were really sad because this was easily our favorite thing to work on. But like, our little peanut butter and jelly toast guys had to go away. And this one does amazing communication work. So the flashcard idea, higher confidence and ability to communicate, lower feelings of awkwardness, greater intentions to communicate. People got it was about alcohol and consent. So what we actually end up doing is we smush them together. And so we took our little PEG people on the alcohol levels that did really good work on like, how much can you drink and give or get consent? And we turned all the little flashcard ideas into their like word bubbles. So there's like all these different versions that have different kind of conversations happening, different communication skills we want to build. And then we were going to roll this out. It was spring break 2020. And we're like, we're going to roll these out on campus. Like, that was the plan. That did not go very, so we're like, okay, this just got put on hold for like a year. And then eventually we rolled it out digital first, and now it's actually out in the real world. And so we kind of offer toolkits to all the campuses, like, here's all the Instagram stuff you need. Here's all the Twitter stuff you need, customized for each campus to build the resources for all those schools. And so it's been like, this is like one of the most fun things we've had a chance to work on. Like, it was really complex, but I wanted to share it with you all today because it's a good example of the way you work through that process and just kind of follow your data as you're going to get to the idea you can feel good sharing in the real world. I always feel pretty comfortable sharing this kind of stuff because it's not about the health issue, it's about the process we go through. And so we do work across so many different health conditions and issues, HPV vaccines and opioids and substance use. At the bottom middle there, actually, you can see it's a hospital-based hand hygiene campaign. It started as a campus-based project. We were doing hand hygiene on campus. And I was giving a talk at a conference, and the person heard me talking about it, and they were like, you know, I'd really like to talk to you about hand hygiene in a hospital. And I never really, I just never thought about that before. And we had the chance to develop a hand hygiene campaign for a hospital setting. We made it freely available to anyone who wanted it. DSHS actually adopted it for some of their facilities. So this is like the co-branded version we worked with DSHS on. We did this 8 years ago as a research project. We made the materials online because we don't care. And then COVID hit, and we just started spreading it to anyone who wanted it. Like, this was an evidence-based hand hygiene campaign, freely available to anyone who wanted it. And so I always like to be like, this was just basic research. So I'm always frustrated when people are like, what's the point of basic research and this, that, and the other? It's like we did this because it was fun. And it was a cool health comm idea. And then it had just incredible value when a pandemic hit, because we could point to data, like observational data in multiple hospitals of like how this helped more people wash their hands. And so we just made it available to whoever wanted it. So I am going to throw my contact information up here at the bottom because I, again, could talk about this all day long, but I think my charge right now is to both say, again, thank you for the chance to get things going. And also, I think I'm going to welcome up our panelists for the session after this, and then we're going to get to kind of hear from them and then open it up for Q&A with everybody. So if my fellow panelists want to come on up, thank you so much.
Hi, y'all. I am Jennifer Shuford. I'm the Chief State Epidemiologist for the Texas Department of State Health Services. I'm so happy to be here with you today. My background is I'm an infectious disease physician by training, but I've been with the state for about 5 years now.
And my name is Clint Pache. I'm the Chief Marketing and Communications Officer at the Greater Houston Partnership. We're the region's economic development and Chamber of Commerce, kind of the business organization here in town. I am not a public health communicator, so I would dispel that myth right off, but got a crash course from a lot of our friends at UT Health, and so I am communicating with the business community, so happy to be here.
Well, thanks so much. So we have a couple of first questions, and then we'll be able to open it up for the audience to ask too, but I wanted to get going, so many times, at least in my experience, people in public health are always thinking about like, how can we use social media more effectively? And whoa, was that a theme during COVID? So, I mean, you come into this from pretty different angles probably, but like, how do you think about the ways we can make the most of social media in service of public health and maybe minimize some of the concerns or downsides that we all saw? You wanna go first?
So we had, I know at the State Health Department, had used social media prior to COVID, but we really saw its need during the pandemic to reach those specific audiences that really use social media and don't use other outlets to get their information. And so I think through the pandemic, we realized that social media was going to be important, and the way that we had been doing social media wasn't probably how we needed to move forward over the course of the pandemic. And there was a lot of discussions about, like, how do we do that? How do we be a government agency who's a trusted source of science, but still can put hopefully somewhat entertaining stuff on social media? And so there was a lot of culture change going on there, and trying to figure out exactly, just like any communications campaign, like, who is our audience? What do they expect to hear about public health or the COVID-19 message? And from whom do they expect to hear that? Do they want a public health official, or should it come from somebody else altogether, who would be a trusted source of information for them? And so we had to adapt during the pandemic, and sometimes learn from our mistakes, but in the end, saw the benefit of it. I think we'll talk a little bit more about it later, but I know that there is also a lot of misinformation and disinformation and on social media. So how do we adjust to that. And I think some of our decisions along the way was, we can't dispel every myth, everything that kind of comes back to us in comments. Though they're important, we can't dispel everything because a lot of that has to be dispelled on a one-to-one sort of conversation between a healthcare professional and them or somebody else who's trusted in them. But that we should maintain just solid health communications, though they can be entertaining or heavy or however, but that we maintain like solid scientific information through the entire pandemic. So I think we saw the benefits of it. We certainly saw the weaknesses of it too, and realized that this is a really particular population that spends their time on social media, but that we need to get messages that were targeted to that audience or intended for that audience.
You got a note.
Yeah,
So I
you
didn't know
know,
if you needed to.
you go and then
just
I'll,
pop up.
yeah.
So, one of our jobs at the partnership that we kind of took on, we here in Houston, uniquely with the Texas Medical Center, there was a weekly, actually, it was 2 times, 3 times a week call with leaders from public health, both at the county and the city level, along with the large hospital systems here in town. Gratefully, the partnership in the business community was invited to that table because obviously we had a large stakeholder audience, not only communicating to employers, but through the employers to their employees. And so one of the pieces that we did, particularly at the partnership, was actually take that leadership group and then find out who their communications folks were and think about, these are public health communicators, and these are also hospital system communicators that are more, I would think of more of like a corporate communication shop. And really what it was, that communications roundtable was brought together really to share materials and best practices. And so that's what I so appreciated, from your presentation, Mike, was really there at the end, taking something you had done 7 or 8 years ago and pulling it forward, and it's still incredibly relevant now. And so in the public health side, there's a lot of materials that have been created that weren't used in traditional hospital systems, or much less definitely not in the business community. And so how do we pull that forward? And, and that translates into social media and that sort of thing. So there's just a great cross sharing of information. And as this group knows, money, I would say from the federal level particularly, was just kind of flowing in and out. There were so many grants and so many things going on. And so particularly, I would say at the city and the county level, when those organizations were thinking about best deployments and how to do that the best, it was the collaboration really between those groups to share the research that they were getting from the different agencies they were using, that sort of thing, to build the best, whether it was social media campaign or just general public health communication campaign. So.
Well, and as my PowerPoint was being pulled down, I also want to let Jason Embry introduce himself. And Jason, do you maybe want to add your first thoughts on kind of social media too as a public health tool?
Yes, thank you for having me, Dr. Macart. And I apologize that I cannot be there with y'all in person, but perhaps appropriately for our conversation, my family and I returned from a great week in Colorado last week with COVID. But fortunately, kids are doing great, and I'm doing much better than I was a couple days ago. So I think we're pretty fortunate in the grand scheme. But my name is Jason Embry. I am with a strategic communications firm here in Austin named New West Communications. And before that, I was a newspaper reporter for 15 years, and then communications director to former Speaker of the Texas House, Joe Strauss. And so it's great to be with this group. And I would just add that I think that social media has obviously been incredibly important in this throughout everything that we've learned and what we've experienced. And I think something that I think is really important that we've learned through that is that what is oftentimes more important than message. We talk so much about message and what the right message should be to reach the right audience, but I think messenger is oftentimes even more important, and we saw that throughout this pandemic, and we have continued to see it. And I think that maybe that's one major lesson is that regardless of whether the message is the correct one, it really matters if you want to reach a broad spectrum of the population that you have the right messengers, because obviously we're in a situation where people put a lot of faith not only in what is being told to them, but who is telling them.
Well, a lot of times, and I know like the conversation on social media tends to be very much around like how do we, and HealthCom broadly, about how do we say the right thing from the right messenger and all those things. But social media can also be a really good tool for listening. So, from the state perspective or the work that you're all doing, like, how do you think of social media more as a listening tool? Because good comm is both saying things, but also listening really well.
Yeah, I think from our perspective, particularly early in the pandemic, again, our key audiences are business leaders in the community, and so we were working closely with UT Public Health. We actually had McKinsey come in. I think they swooped in every city, everywhere. I think they did pretty well, but it is thinking about how when we were looking at the feedback we were getting, they were just saying, what are we supposed to do? Which was like so interesting because I mean, these are like CEOs of companies or their communications folks reaching out to us on Facebook or Twitter. It's like, just give us the information. And so that actually guided us in our conversations that we were having with the Texas Medical Center and UT Health and others of, okay, hey, we don't have the full guidance yet from CDC or what are we supposed to be telling these people? And so, and again, everybody was kind of scrambling there at the beginning, but we were able to get out and working, I would say, with Maria Fernandez at UT Health and Christine Markham, UT Health, and thinking about, okay, based on your previous experience, we know we're in the middle of a fire drill now. What are the 5 best ways that we can say this? And we just picked that up and we went and we took that. But that was based on that listening that we were doing in social of people were just raising the red flag saying, please help us now.
Yeah.
So I think we learned a lot of communication lessons at the state during this. And one of the things that we had been doing is doing these daily and then twice weekly and then weekly phone calls. And one thing that we were able to do, and so we did this for people across the state, educators and politicians and healthcare professionals and public health workers, is that we were able to get messages out to them, data out to them on a regular basis. At first, we would get a lot of interesting feedback on our phone calls because we'd always open it up to questions and answers. But in those were always nuggets of truth about how we needed to be adjusting, what we were lacking in our communications that they needed. And so, but that is kind of a long turnaround period, and it's only to a specific audience. And what we've learned with social media is you get immediate feedback about where your communications are lacking. And so, though you have to know, like, this isn't necessarily representative of the entire population, it is an important audience, and you do get to hear about, as long as you keep an open mind, about where are the gaps in your communication, where is our message lacking, where could it be strengthened, as well as a lot of our other activities that we're doing, our website or whatever. People are going to tell us via that mechanism about where the gaps are and how we can improve.
Yeah, I know, at least in our experience too, I would also just add to that sometimes you don't even know what questions you're not asking, because we pulled, we were doing a community water fluoridation project, and we pulled every tweet in Texas for like a calendar year that had fluoride in it. And one thing we learned that we never would have thought to think about was there was a lot of I would consider it like low-level shade being thrown at fluoride by commercial water filtration, like home water filter systems. We're being like, it can take out like the dirt and the bacteria and the fluoride. And like, it was like just like this low level, like fluoride's not good. And it might be scary because it sounds like a chemical, because it is. We just never thought about like that being a thing that was like going against some public health messaging you might want to do. And it was only because we did like the active listening to kind of pull in to find out something that was like a conversation we could pay attention to if we decided we wanted to in messaging. Jason, anything you want to add about kind of social media listening?
Yeah, I would just add, I think that concept of social listening is increasingly important and a really good one. And I think that, for all of their flaws, and we all know that there are many flaws with these social networks and with Facebook in particular, it is kind of like having something of a focus group right there on your phone. If you take it with the with the needed context, you recognize that you're only seeing a certain part of the population in each person's feed, but still there's so many different issues that we work on in our firm. We find that things, Facebook is in discussions and comments are often a preview of what's going to be in the news in the future, and stuff. It's so often an opportunity to preview what's coming in terms of the public dialogue.
One thing I'll add, because I know what we're going to shift is, for those public health communications folks that in the audience are watching, is think about how many more subscribers and followers you have now than you did before the pandemic. You would have paid millions of dollars to get those people to follow you before the pandemic. And so I don't have the answers of what you do with that. But it is an incredible opportunity that you didn't have before that you have now, of these people that see your resources that you're provided as a trusted source. You're a trusted voice. And so how do you continue that chain of trust, continue to build on that trust, and leverage it to improve public health in the long term?
I remember doing one or two of the first talks, like April, May of 2020. And I was sort of explaining in these talks, I was like, well, we don't know what's going to happen, but two, like COVID was the world's worst health com problem. Because I remember the month that I was wiping groceries down with Clorox wipes. And that wasn't because it wasn't that we were wrong to think that might be what we needed. It's like, that's what we did. And then we learned more and that changed. But that tended to be perceived as like, oh, you people don't even know what you're talking about. And so like from kind of like the state perspective, maybe to start, like, how do you think about good communication and being able to change and sort of be like, well, now we know a little more and here's a new change. Like, how do we change what we know, change what we're saying, and kind of maintain that credibility and trust as people who actually do know things? It's not that people who did it really well were still wrong, because we learned new things over the course of the pandemic.
Yeah, no, I think this is like maybe one of my biggest lessons learned in communication through the pandemic, is how to recognize or communicate upfront, like the things are going to be changing. And I think as like a physician, scientist, like I'm used to things changing. Like I know that this week we may tell everyone to take an aspirin, and next week those recommendations might change because medical research is changing all the time. We get stronger evidence and we change our recommendations. And that's like expected in my world, but that's not expected in everybody's world. And I know that when a new virus comes out, we're going to make generalizations about it until we have more specific information about it, and that things are going to change. And I don't think the general population, it's been very clear that that wasn't the expectation. And so I think that some really fantastic communicators at the very beginning did this. And I know that it was lacking in my communications, just to say up front, this is a novel virus. We have not seen this before. I am going to say things today that might change tomorrow, and that's because there's so much research going on, and it's a good thing. We're going to learn new things, but just know that my information and my guidance is going to change. And so prefacing everything with that would have been helpful from the very beginning. As we went along, though, we recognized that it was important that we keep those messages to the public really transparent. But genuine, telling them, like, I recognize that this is a change from what we told you before. And the reason is new research came out and this is what it's telling us now. And so that's why I'm telling you to do this, and to try to keep the message really simple, but to communicate why we actually did it. So it's not some black box. I'm not saying I'm smarter than you and you just need to do this, but there's things happening and that everybody is going to need to change just because we have more information now.
I'm gonna let that answer stand. That's a great answer.
Jason, anything you want to add to that?
Yeah, it is a great answer. I would just add, I sort of think about what you were talking about during your presentation, Dr. Macart, about framing and how important that is. And, in the early months of this, there was so much focus on, and understandably so, we were all asking this, when is it going to be over? And what's the end date? And you have figures talking about, when we get the vaccine, we get back to normal, we go back to restaurants, people go back to church and all of that. And I think that framing of when will this be over, which was an entirely reasonable question and thing to be wondering, I think has made it difficult for people to comprehend and to deal with the longevity of this and the changing nature of it. And once that initial expectation was set of there will be an end date at some point, and certainly there were people in the medical community cautioning against that, but there's so many voices out there in the media talking about if we just get to this point, we'll get back to normal. That I think we've sort of been playing catch up ever since.
And one thing I will say, and this is not, and I know a lot of communities did this, but I think, here in Harris County, like many other jurisdictions, kind of had the color scale, and it was like, we're at red, we're at green, we're at yellow, we're at orange. And, at some point, thresholds were established in there. Okay, if we get under this number, then we can shift from this to that. And unfortunately, that was well thought and very well intended, but I would say we're definitely boxed in on, hey, okay, when we get below this, then we're going to do this. Well, the reality was it was more of an amorphous situation. And as new science came in, maybe those numbers might have adjusted, but it's hard to go back and then adjust what those thresholds are once you've done that. And so I think it definitely created a challenge for that entity, particularly here in Harris County, where, not for political reasons, people had started going about their lives and the county was still sitting at red. And all of a sudden, then they had a credibility problem because, they're even standing at a press conference, like they weren't walking in with their masks on, but they sure put them on because that's what the threshold said. And so again, I don't think it was their fault. That was the best science they had at the time. But you do have to be careful in thinking about something like this that is changing so much. Don't put a box around yourself. But the transparency and communicating, hey, this is going to change is incredibly important.
So for 2 years, especially that first year, I think it was in the same day sometimes, like public health would be criticized for communicating too much and then also not communicating enough. And so how do you think, like as a field, public health can do better sort of hitting that balance or understanding kind of that line of over and under communicating?
So I think that for the state, from our perspective, it was really challenging, even from the very beginning, because there were times that we were getting information that sometimes no other people weren't getting. And so we were getting some information feeds from CDC, who were getting it from other international health agencies. And so we had information that we needed to get out to particular audiences, like public health or healthcare professionals. And so for us, we did have a lot of messages, but I think in the end recognized that there's some really detailed information that needs to get to certain groups and to have established forums to exchange that information. But the public doesn't want to know every time one little new study comes out that might change how we think about some of our guidance as in that healthcare professional or public health professional realm, but it might not impact what they're doing right now on a day-to-day basis. And so I think establishing different forums to share that information and keeping the information for the public like that we put out through our social media or some of our other campaigns a little more stable and simple if we can, so that it's not always fight or flight. It's not always like, here's something else that you need to worry about today. Let people have a chance to try to make some good decisions on their own with some information that we have. But I think that another thing that we learned is that I've talked with some of y'all about is how do we find ways to get information to people in a way they want it and that they can use it? And I'm not sure that in public health, we always did that. And I know because like the New York Times dashboards were really popular, and Johns Hopkins, was really popular. And they were getting their data for Texas straight from our website. So we all had the same data, but they were presenting it in a way that people could absorb it and use it. And so how do we then judge our audience about what they can use and then provide it for them locally or statewide?
Yeah, I think that, and I know the afternoon conversation really does focus on that, it's a single message to, very specific audiences. And that was a huge piece for us. One of the other pieces that we did was also holding standalone, and Dr. Borwinkle helped a lot with this, there was a group of faith leaders that, when you think about the trusted categories, it was like my doctor, my employer, and then my faith leader, and insert that, whatever that title is. And so we got to, I think it was about 700 ministers was the list of folks that were involved in these calls on a weekly basis. Because again, they wanted to be saying the right things, and they knew they were the trusted source for their congregants, but they also didn't want to be misleading people. And so even for, if you think about kind of the megaphone of communications, and I think of really public health communications, we're really taking the lead on this because A, y'all knew how to do this, and B, you knew the right things to say. but then how do you build the trust with those next layers of the megaphone that are going to be communicating out that message? And I think that the other piece I'll just add is, particularly early on, I think elected officials felt the need to go out and project leadership. And so that involved, a press conference a day at each level of, think all the way from the White House down to like a city or municipality level. And what that does for public health communicators is obviously they would be right beside there. The Harris County Public Health would be standing right next to the county judge or next to the mayor or whatever it might be. And what that creates is the opportunity for, you feel like you need to say something new every day. If you're in front of a microphone or a podium every day and you really have to stick to those core messages, and if nothing's changed from yesterday to today, A, don't make up something, but B, if you're hearing things on the back channels that are not out public, you have to be very careful. And because in kind of, I don't say the fog of war, but that confusion time, that's just going to exacerbate that. And then you're going to get criticized for changing your guidance and things like that. So it's just a unique circumstance. Jason.
Yeah. And I would also add the aspect of the news media and that they're, the fact that they do feel like they have to say something new and something different every day. And so you have a very, especially on a major international story like this, you have a very competitive news environment where everyone is trying to get the latest information, get it out first, get credit for reporting it first. And not only does that feed sort of this sense of there's just too much information coming at me, but you also, as a communicator, you also have to think about the fact that the news media, when they have something significant, they're going to put it out, not just, put it on their website or put it on the news at night, but there's going to be a breaking news email. We all get probably too many of those per day. And there's going to be a push alert to your phone. And of course, all this stuff on social media. And so I think that just the news environment that we're in, being highly competitive, being just that minute to minute cycle that never ends, adds to that sense that there is over communication going on.
Yeah, I think part of that too is it's really easy to forget all the other people who are saying similar or related. Like I was talking to Julie Robner from Kaiser Health News. I was talking to her and she was like, "How would you grade this?" Like a year into the pandemic. She's like, "How would you grade the government's communication?" She's like, "You're a professor, grade it." And I was like, "Oh, I feel like this is a trap." And so instead I was like, well, like, yeah, but I was like, well, which government are you talking about? Is it like the federal government, 50 states, a billion cities? Like it's like there's a whole range, just like there is in my classes. But it's really easy if you're just one group. Like it's hard. Like why would you keep track of what everyone else is saying? Like it's really hard. But like that contributes to the overload. It wasn't DSHS was doing too much. It's DSHS. Like if you're on the receiving end, it's like pulling it in from every single angle, like that, it's overwhelming as the user, not as the person sending it. I think it's hard to kind of keep that in your brain. So historically, public health is very like tied to governments, whether it be the CDC, state health departments, local health departments. And that's not always the most trustworthy source for certain audiences. How do we think about maybe both rebuilding that trust and also like taking advantage, like Clint was mentioning kind of faith leaders, but like how can we and public health and comm do a better job tapping into people who are already trusted to help spread those messages in ways that are credible?
Yeah, I think it's an interesting question because it is so true how closely these things are linked. And obviously, I mentioned different types of press conferences. You had in Harris County in particular, it's a Democratic county judge, where obviously at the state level, a Republican governor talking. And I think what's important is behind the scenes that the public health people are all synced up on their messages. Because again, there's gonna be certain audiences that are gonna listen to that judge. There's gonna be certain audiences that listen to the governor. And so in as much as they can coordinate and work together to have those set messages and apply those consistently, and honestly avoid some of the political pressures. And the reality, we like to say those don't exist, but they do. And we would hear those kind of in the back channel conversations. But I think for the long-term success of public health entities, as they were, again, you will probably always be connected to a political subdivision in some way, shape, or form. But as best you can, kind of maintaining that, I don't say I don't say the moral standard, that makes it sound like politics is immoral, but taking that scientific background and then closely linking on the backside.
It's an excellent answer, and one that I think we've thought about at the state level and the national level about how we can better communicate and reconcile our messages so that we're all giving the same message. And I think that, as you mentioned, there's differences in some of the local politics and state politics, and so this is one reason why it's so important for us to really build strong partnerships during a pandemic, but in the interpandemic periods as well. So there's times that we're going to have constraints at the state on some of our messaging, but that local health departments might not, or university systems, or other professional organizations. But having that strong communication behind the scenes can help us all push forward our messages, and people can push it forward in the ways that they can with the audiences that they have. So, but it has been a challenge with having sometimes academics or other public health having a disparate message. It really does decrease trust. So I think in this time where hopefully we'll see decreasing COVID cases, we'll have a chance to really strengthen those partnerships and partnerships with trusted community members. We know that's been important for vaccine messaging, for getting some of those actual rates up and getting messages out to really heavily impacted populations. And so we'll be working on building those relationships too. I think you're right that they're going to be instrumental.
Jason, anything to add to that?
Yeah, I mean, I think this is sort of a really important point when we talk about the whole context of the communication around this pandemic, was just the degree to which it became political. And Dr. Hellerstadt was talking about, that this was about society. And I would take it a step further to say it was really about politics. And that was that was unfortunate. I think we would all agree, but it was unexpected. It happened to be an election year. And if we were to have another type of national crisis like this, 5 or 10 years from now, I don't know whether it would fall along those same lines, but I certainly think that we should be informed by the fact that we certainly in 2020 and probably continue to be in an age where it's almost naive to think we're going to agree on a basic set of facts. And so how do you plan for that reality, and how do you identify the right people to reach the right audiences? Because so much of this, I think, from the very beginning was tied up in political considerations and in election year politics at the national level. And so much of what happened, when you're in a national campaign like that, it drives so much of the conversation down to local markets throughout the country.
Okay. Well, maybe I'll have one last kind of question, and then we'll open it up for the audience. So I'm curious, maybe the last thing each of you can respond to is, what's something you learned over the last 2 years that you kind of want to carry forward, not just thinking about some future pandemic or the rest of COVID, but like to other work that you're doing, that kind of like a lesson learned that translates into making us better broadly going forward?
I think it's it really did emphasize this concept of trusted voices. In this, when I guess everything's going badly, like who are people turning to get their news or information? And so it's thinking about it as a communicator and put it in the public health perspective. How would we, or how would you in your field leverage faith leaders? There's been these tremendous networks built up not only in Houston, but I would imagine in other cities around the state and around the country. How do you leverage those folks and these people that have been brought together to then do good going forward? It's just like leveraging the social media contacts. But really communications is about knowing your audience and and have clarity of message, knowing your audience, and then delivering that message in a way that your audience will understand it, which comes through trusted sources. And so I think for me, and whatever I ended up doing next, I started out working for the Astros, so I've had a very random career. But how do you identify and then leverage those trusted sources?
Want to go, Jennifer?
Sure. So I think that for us, it's been One of the lessons learned is that our partnerships and relationships are really important. And it's not something that we always focus on at the State Health Department, where we're worried about kind of quality of data and things that isolate us, and rather than building strong relationships with other local health departments or with community leaders. And so moving forward, I think we're going to change how we foster some of those relationships. I hope that holds true.
Awesome.
And I
Jason?
think it's important, just to pick up on the point about trusted voices, which I completely agree with. I think it's important to be really open-minded about that and say that, even in a health crisis, that not to a lot of people, a trusted voice is not going to be somebody who's maybe high-ranking in the CDC, for example. And I think again, one thing that I think has really been made clear over the last couple of years is just the shift in who are the media voices that people really listen to, and that there's such a variety, that there are folks out there who rather than listening to an expert from the CDC or even a traditional news presence like Savannah Guthrie or somebody, would rather get this type of information and really trust it from people that are coming into their ear every day, like a Joe Rogan or a Pat McAfee or Howard Stern or whoever those folks may be. That we have to really be open-minded about the fact that that there is not universal agreement on who is to be trusted.
Awesome. Well, thank you so much for all the past. I'd like to open up for the audience. Who has questions on anything we've talked about so far? Any questions in the room? I think if you raise your hand, I think there's going to be a mic run over to you to make sure that the people on the virtual part of the meeting can hear the questions too.
Thank you, all of you from the panel. I actually have several questions, but I'll ask one for the panel first. I'm just curious, as you guys discussed a lot about, within changing infection information and rapid communication type of issues. And I'm just wondering, as COVID takes on a little bit more of like a long COVID and chronic disease kind of ways, characteristics, and then mental distress is becoming more of an issue. And I'm just wondering how does that change the way you communicate with these other entities like business groups, how they communicate with their workers, what they can, what are they able to make accommodations for. So I'm just curious, as like thinking about from infection, rapid communication to long COVID and chronic disease communication, type of issues, how do you change that? Thanks.
Yeah.
It's an excellent question. And, it's something that in public health, we're kind of segmented. We've got our infectious disease EPIs and our infectious disease response and more of our chronic disease. And our communications, you're right, are different between those two. And so right now we're trying to figure out, like, how do we incorporate some of that surveillance for something that is more of a chronic condition but comes from an infectious disease, and then continue to do disease surveillance on it, but then communicate all of those findings and recommendations out. And so I think it's still a work in progress, but we've learned through this that it's really important to keep those messages going out on a regular basis with what we know, to be transparent about it and to help guide some of these different sectors, like you mentioned, businesses that really are going to be concerned and impacted by this.
Yeah, I think frankly, the business community, at least that we're with, has moved on. And so, unfortunately, and so thinking about, I mentioned, all the resources that have flown into various entities, and I do think it's important for those entities, governmental entities and public health departments, it's very easy to take those COVID funds and apply them to something else. And so how are we funding these long-term campaigns? Because it is a real thing. It's going to impact people, and not squander those dollars, because otherwise down the line, this is putting on the business community always talk about efficient and effective government. This is one of those things that's really, really important, to use those monies for the intended source. Because honestly, unless it's coming from the insurer or the insurance company that my business is using, and they're going to start charging us more because of the impacts of COVID or long COVID, they're not going to pay attention. I don't think so.
Yeah. Other questions? there, Mike back there.
I have a question. So, in the ever evolving situation that was the beginning of the pandemic, and you, in a lot of cases, people who are serving in a communications role are serving as an advisor or in an advisory capacity to state leaders, local leaders, et cetera. How do you reconcile the message that you want to present and that maybe you feel should be presented from your team versus the message that maybe there are other pressures to send out at the level above when you're serving as an advisor in that sense?
One way that we've been able to do that is to present data kind of straight up, and so that there's no political leanings on it, that we can just say, this study came out and showed this. And so we've been able to communicate some of the strength of the science without kind of going into policy areas that we don't want to necessarily go into, because we're interested in a lot of cases of just sharing the science. And so we've been able to do that and try to just keep it clean that way.
And I would just add, oh, sorry.
Yeah, go ahead. Sorry, go ahead.
No, that's okay. I was just gonna say I would add it's great to pull in experts and those who are maybe not in political office and take advantage of those messengers who have that built-in credibility, that maybe can play a different role than those who are and have elected considerations.
Yeah, as we're getting ready for the next question, I'd also add that, as the university, there are one of the reasons we test who should a message come from, this alcohol and consent thing. UT students are very okay on the Austin campus. They're really okay with the university doing the safe sex promotion kind of stuff. You can go in the student services building and get some free condoms, and students think that's normal. They don't want the university telling them about drinking. And so so if they want to do high risk drinking prevention, they'll work with other for the people on campus who do the work, they'll find other ways in that their audience is going to find acceptable. And so I think that's another part of doing that good comm work sometimes, is finding other ways to get it done. Scott Gottlieb, who used to run the FDA, we had a conversation with him a couple months ago, and he said he worked really hard to find ways around some of the bureaucratic things. So he was it was a commissioner statement, whatever he called it, so it didn't have to go through 17,000 layers of approval. He's nope, that's the thing I'm saying on Twitter. And I'll tell you ahead of time, but I'm not waiting for approval. I think finding some of those gaps or ways you can get it out that kind of work within the system too can be another kind of approach maybe.
Yeah, hi, this is John Hellerstadt. I would just want to make clear that as far as my leadership, we were never asked to do anything other than present the facts, ever.
Thank you. Yeah.
Hi, Eric Borwinkel. One of the good things that's come out of COVID is the forging of new partnerships. And Clint, you referred to it a couple of times. So how do we now, not in a post-COVID, but with COVID, sort of leverage these new partnerships towards other diseases? During COVID, heart disease, cancer, stroke, I could go on, they didn't go away. But it seems like we could leverage these new partnerships and leveraged what we've learned to tackle some of these other major public health problems going forward. And how do we do that and avoid, to use your words again, Clint, that, X has moved on. We're going to move on. There still is a lot of disease out there. There's a lot of suffering out there. There's a lot of health inequities out there. It seems like we could refocus some of this energy on some of those important points in public health to continue to make an impact.
Yeah, I think particularly I'll speak with for the faith community, that group that was built up, those 700 folks, I think they would welcome the opportunity. You may only get one shot, but to bring them together in a setting like this, and some of it celebrating some of the successes and stories from that, almost call it a recap, because like you said, with COVID, but then maybe present some of these challenges, just kind of like you did, innocently, using the example of the consent and alcohol piece. That was very, very informative. And so if you did that with those trusted audiences, really, if you picked, here are the top 3 health challenges, And when we think about, being very real about these are your communities, these are your congregants that these are impacting, whether it's, a race ethnicity thing or an income thing or whatever it might be, then you can take it from there, let people raise their hands, and then build a cohort of folks that, you're going to tackle, obesity in certain communities or whatever. And again, but take those relationships, you have one shot to communicate them to them one more time, and then see what you can build off of that.
I think one item I would add to that maybe is it's also requires, if you're like the state or a local health department, just being more open to some of your partners not being like perfect in every way before they become your partners in communication. I think there's so much value in like social media influencers. Like why in public health the tendency is, or medicine too, I'm working with a lot of med students on the social media projects. And like, until I tell it to them, like, they're always like, how do we get more people to follow like trusted physicians on TikTok? And it's like, or find the people who already have 1 billion followers and like have them become your partners. But I think if you're an official government entity, it's really hard to be like, well, there's that one post they made from like a year ago that's not the best. And I think it's really easy to say no to those new partnerships. And I think COVID sort of forced some relations partnerships that probably wouldn't have been like made it through all the way previously. And hopefully like knowing that these people are trusted resources, and how can we sort of take them as they are and make them kind of partners in getting good messages out, and not just be like, well, the one thing they said the one time a really, really long time ago maybe just makes them unacceptable as a partner in this effort. I think just accepting people as they are, I think would probably be a little bit helpful too.
Yeah, I can say at DSHS, we ran into this exact thing at the beginning of the pandemic. Our comms folks, who are fantastic, came to us and said, hey, we want to get these messages out. Can we use these influencers? And we'd never done it before. We were like, oh, and I know I personally was like, oh, I don't know about that, and then within probably a month later, we were doing it. And it was one of the most effective ways that we could get the message out. We got so many retweets or views on those particular messages. And I realized like how important it is to listen to our comms folks that really know what's going on and are in touch with communications, and how important those finding those partnerships really is.
Other questions here in the room? Or I don't know if we have questions in the chat too. Okay, we want them here.
Thank you. This is Fuqing. So thank you for this panel discussion. I echo one of the points that you mentioned, that is getting the right message to the right audience. So you guys talk about a lot about the communication and the social media. So I think social media is important for the communication, but there's also like right now we are especially about infectious diseases, and we are hearing so many news messages about infectious diseases, COVID. And I believe many of them it's not like have the same review process before publish. So there are some misinformation, disinformation. So I want to hear your comments about those messages, misinformation things. Thank you.
I mean, I think it's kind of like you said earlier, it's leading with the data and the science. That the best way to combat false narratives is with the truth, and being very consistent with that, and not wavering. So
I know that we try to do that by being transparent, telling our sources why we're saying something and how we've come to that conclusion. But it is hard to dispel all of that misinformation or disinformation on a widespread. A lot of that is it's within their communities, and that there needs to be some one-on-one communication with people that they trust to change all of that. But I know that we can maintain our trust with a lot of the population if we just stick by those messages and be transparent about them.
Yeah, I think being realistic about where can make a difference too. Like if that's one thing I know certainly that wasn't the case. I think everyone like 10 years ago was like, oh, the way people thought about social media wasn't necessarily thinking about it as I can find literally anything to support any decision I want to make related to my health if I go looking now. And it can really spread really effectively, and trying to be realistic of like, it's not in COVID yet, I don't think, but in other health issues, there's been some data that like the myth fact construction we tend to do actually doesn't work. And there's the other downside of like, if someone didn't already know the myth part, like then in doing your myth fact knockdown, like you're telling people about the misinformation as you're knocking it down. And so like that construction, like in the work that we do, like we don't do anything that's like myth fact setup, like as like the message, because it's doesn't work. And it can spread misinformation. And so I think there'll be a lot more work going on specifically because of COVID that's gonna probably be helpful for lots of other health issues around misinformation. If you're ever interested, there's a conference of healthcare journalists. There's an association. They do a conference, and like misinformation is like one of the biggest things that health journalists spend their time thinking about, is how they can do a better job as health journalists and kind of be conscious of that misinformation environment in the work that they're doing too.
I also think it's important to remember that context, speaking of health journalists, that, you know, we're in a media environment, and especially on more the state and local level, where, you know, because of economics, you have fewer reporters, you have fewer people doing the work of journalism, and they generally don't have much expertise in a lot of these issues. You know, you have folks at the New York Times who have been studying infectious disease for years, but the folks at your local newspaper or your local television station may not be that way. Now, I know that in Houston there are some outstanding science journalists, and so I certainly don't want to discount that, because I think those of you in Houston are fortunate than most. But I think when you see something in the news media, know that it may not necessarily come from a place of malice. It may just be someone who, you know, a couple days ago hadn't been asked to cover something like this. And when possible, I do think it's good to, you know, politely, respectfully reach out to the journalists, you know, and have a conversation about, you know, hey, I saw you reported this, and here's something you may not know, and please consider this in the future. And I think journalists are still very attuned to wanting to get it correct.
Great point. Yeah, we have two more questions over here.
My name's Kyle. I'm with MRG Health and Smart Care 360. But with regards to communication, I mean, you have the pandemic, COVID. There's all kinds of chronic diseases that are out in the public, you know, sector, just the community, and there's all kinds of ways to communicate. You have automated voice, you know, messages or calls. There's, you know, text. There's all kinds of educational ways to communicate, video. With that, there's technologies, and it could do a lot of different things to help with the communication, but you also need people. And with all these new care models and all these new billable, you know, CPT codes that are all time-based and value-based payment models, you need people as well. And these people are communicating with patients and educating them through different, you know, modems. But have you guys looked at the future over the next 1, 2, 3 years, and how are we going to staff up those needs to serve these different communities as we're having, you know, 10,000 people a day turning 65 and all these other factors that are going to really affect us in the future if we don't think ahead of the curve?
You can take it.
Okay, okay. I'll give you my answer for the way we think about some of the education stuff that we care about. We are very interested in, like, so we have a minor for undergrads at UT. It's all pre-health profession students. Like, they're not the comm students who want to become, like, there's one I've had who are like, the next great health documentary filmmaker, like that student exists, but they're almost all people who want to apply to med school, nursing school, dental, like, and also want to write in their application, like, I know how to talk to people. But when we think about, like, and we like master's degrees and all kinds of things, like a thing that, like, we're particularly just kind of excited about, because a lot of people who we think could be better and would, like, are interested honestly in, like, being better communicators. It's like thinking of different models of training people. And so we actually just, like, recently launched an online ed program, and it's built to be like 1 hour asynchronous education on health comm. And we've been planning it long before COVID. And one of the PhD students on the comm side of our school, like, on our steering committee, she's like, isn't this technically now relevant for, like, every high school, elementary school, middle school principal in the country? It was like, you know, hadn't really thought about it that way, but yeah. And so I think it's just thinking about ways of, in the comm context, like thinking about how we can give people really helpful, quick training. I would also argue, we work with one of the physicians in the Del Med side says, like, you don't get better at communicating because of a 3-hour workshop. It's like ongoing. It has to be like a theme in an organization to, like, and like one-on-one coaching, because everyone can go and say, like, oh, the best way to communicate to a patient and double check they know is teach back. Like, it's just 100%, like, it works, because you can find out if they know and understand what you said to them or not, but it takes time. And a lot of people are going to do it for like a day, and then all the pressures of their job are going to take that away. And so it's like an organizational commitment to good comm. and I would argue like lots of quick trainings over time versus like some really in-depth thing for 2 days that's gonna fade for lots of reasons. I don't know if that's a total answer to your question, but it's like where I go thinking about how we can kind of build the important comm skills that everyone knows they need and have them like last and be better over time.
So I'm going to go ahead and jump in here and add an online question because we have several. During the discussion about the individuality of the intended audience, we received a couple of questions. What about communicating messages in different languages? And let me add on to that. How do you deal with the nuances of translating health messaging to other languages, since a lot of words can lose their meaning when translated?
I mean, I can just say from the work that we do, a lot of times, like everything we do for the state is automatically translated into Spanish. Like that's just like part of the work. When we think about what we're doing on the research side, I would rather fail first faster in one language. And so we tend to do that. Like a lot of our early stuff is kind of just done English first, but the end result is always kind of translated once it's there. I think the note about how words can lose meaning, I think is really valuable. I don't know if this is technically possible at the state level, but I think it'd be really cool because everything is by default English and Spanish. There are so many different languages spoken in the state, and it's probably not really within the resources or logistics to do everything. Like I would love it if there was a way to crowdsource translations of materials and then help them spread afterwards. And so like, I'm sure there's like logistically liability. I'm not a lawyer, thankfully. I think there'd be a lot there, but I think there's other ways to kind of do a better job on the comm side and making sure translations aren't just like the Google Translate version, but like the meaning is there. How you do that at scale is hard, I think, but it would help a lot.
Yeah, it's challenging here in Texas. We have so many different languages being spoken, and this is the perfect Houston, Harris County for sure. And so at the state, we do keep people on staff to do, or be in our larger HHS system to do the Spanish translation. And so that can be turned around really quickly using native speakers that have the information to be able to know those nuances. It's more difficult with other languages that it can be really important. And at the beginning of this pandemic, we were trying to get things translated into Chinese characters. And that was challenging, finding contractors to do that. And you can see how different messages might be needed to target different people groups. And so I think that is a challenge that we're going to face and try to address in coming months to years.
And the only thing I'd add, that's the scale piece. Like we have, we know some of the folks who did the big national level campaign, hearing the logistics of how that worked for them. Because every time the CDC would be like, oh, it's not 8 feet, it's 6 feet. Like every time there was like a very small tweak in the like recommendations, they had to go through and find like every single material that had the older recommendation, update like hundreds of files and get them all double translated. Like the behind the scenes logistics that were really, really hard. And so I think like the more languages you add, like they are all really important, but it like adds additional complexity to be doing it quickly and really well. So
we absolutely struggled with that. This is an excellent point.
I'm happy to add another question here. If somebody is very happy that you discuss political influences on health-related messaging, and this person would love to hear more about that. But let me ask a question. What type of messaging did you all promote through influencer partnerships?
Sure. I know that some of this was just the non-pharmaceutical interventions early on that, we didn't have a whole lot else to offer. And so the masking, staying home if you're sick, and physical distancing, as we move further, using them for our immunization messages. And they've been, like I said, really successful and something that we've now adopted moving forward, but that was challenging to accept initially.
In terms of politics and health comm, I don't work at DSHS or anything. The thing I think I would add is I have a grad student right now, like COVID became very politicized. I think there's ways we probably could have done a better job, like leaning into that in certain ways, like freedom to go back to school, freedom to go back to restaurants, like there's a lot of things that I think if you could do it all over again, we probably could have taken advantage of that in some ways and made it messages that would work for different people from different political backgrounds where that's really motivating them. One of my PhD students right now is working on her dissertation idea is partly thinking about how basically every health issue is either already politicized, maybe not as much as COVID, or it can be if you kind of nudge people a little bit. And I think there's a lot I think that she can learn and kind of advance the field, and we can all benefit from just like understanding how that politics and health comm are going to just continue to interact forever. I think there's just a lot of really good work to be done there that could make, I think, everything coming from any government just more effective too. So.
And I think, you know, from the state agency perspective, we've got, we like to say 181 bosses downtown, you know, and from different political parties. But one thing that we also have is access to a lot of those elected officials. And so that we can get communications and education to them. And so I think there's ways that we can use that a part of being a part of government to our advantage.
Yeah, you know, it goes back to the trusted sources. I mean, elected officials, I mean, they obviously are trusted by a large group of folks to be in that position. And so how do you leverage those in the long term? That's a great point. And that covers naturally the political spectrum. So.
Question here.
This is a question related to several things that we've been talking about, and it's fundamentally a question of translation and interpretation, but not between languages. One thing I think is important in communications is being able to translate the science. As you talked about, science is the way to establish credibility and truth, but understanding that health communication is reaching a lot of different audiences. We're reaching journalists, that's a sort of intermediary that can be done at a high level. And then there's business leaders, which is another one, and then there's the public. So the importance of being able to translate the science. It's stuff that we've mentioned here. I mean, Dr. Hofstetler mentioned it originally, that term fully vaxxed, which is a term that we use often, or the issues around the changing things of masking, or even the fundamental scientific principle of a theory, things like evolution, which we've been dealing with for decades, right? So I would love to get your thoughts on that.
If you want to go first.
Sure. So I think one of the things that we struggled with was that there are ways to simplify the science to a message that people can absorb a little bit easier, but it takes time. I mean, you know, it's easy for me to read an abstract or read a conclusion from a scientific journal to people, but in order to really distill it down to the important points and use language that people can understand, that just takes time. And it took time when we had 1,000 competing priorities, you know, that we were trying to do all these different things, but still get that message out by the end of the day. And so I think sometimes that kind of way to translate the science did get lost, partly because of the time rush, but it's inherently challenging. And I know our comms folks would try to do that distillation for us and then send it to us for our approval from a health, you know, medical perspective. And me sending it back to them with like 15 more words, you know, and then sending it back to me with fewer words again. And that iterative process did work in the end, but it does take time and a lot of concentration on my part. And so sometimes the time constraints we had just didn't allow for that solid communication that I wish we could have every day of the pandemic.
So I want to say thanks to all of our panelists. This is a really good conversation. The questions from y'all were amazing, and I think it sets us up for kind of lots of good conversations over lunch probably too. So I don't know if there's any other announcements from our organizers, but just want to say thank you again to all of our panelists for all the conversation today.
Thank you.